Hey everybody, it's Chris here with the Main Points Podcast. Today we're talking with Mary Garrison. She's the president and CEO of Heritage Behavioral Health here in Decatur. I'm really excited to talk with Mary today. I want to know more about really the history of mental health, and I know we'll get to that, but really, how does the community look at mental health and some of the stigmas that are there and what her and her team are doing to help dispel some of the stigmas. So really excited about this podcast and look forward to you joining us. Today we have with us Mary Garrison. Thank you for joining us, Mary. Mary is the president and CEO of Heritage Behavioral Health Center since 2022.
Yes.
So
can't believe I'm into my third year.
There you go.
Time flies.
Time is marching on. And I think we were just talking off air too, obviously about COVID, and that was kind of defining. And, a lot of things are defined what was before COVID or after COVID.
Absolutely.
And now all of a sudden it's like, we're getting a few years removed from, I think, the heat of that now.
Yeah,
so
we are.
Adjusting, and we were talking about the good things that have come from COVID and
Yep.
certainly the unfortunate things that happened during the pandemic.
And I think the other piece is everybody lived through it. We all did, right?
Right.
In
We're
the
here.
world.
Yeah.
Here we are.
The
So
ones
we
that-
have that
yeah.
similar connection.
Yes, absolutely. So, well, very good. Well, first, tell us a little bit about yourself and kind of how you came to Decatur, or what your background is with
Okay.
Decatur.
Wonderful. So I came to Decatur about now 17 years ago.
Okay.
Well, actually, now that I've been here in this new job, about 19 years.
Okay.
I came as to be a professor at Millikan.
Really?
So I had been working in behavioral health in Bloomington, Illinois, and I was doing a side gig of adjunct teaching at the U of I. Loved it. Had no desire to leave my role where I was, but someone mentioned there was a faculty position open. I said, why not? And I was like, I hope I get this after I interviewed, and I have been thrilled. So 17 years as a professor of social work.
Okay.
Teaching courses related to social work, teaching courses on behavioral health, actually, and trying to build up the workforce. I remember it working in the field early on that we needed folks coming in to understand mental health and substance use. And so loved that, loved Millikan, had no reason to leave, except this opportunity came up. Someone asked if I had interest, and I thought, okay. And then after my first interview, I said, I hope I get it. It's going to be a wonderful thing.
Okay.
It was, I've been fortunate to have really, several roles that I would have stayed in my whole career. So who gets to say that, right? And so, and this one is just as wonderful.
Right. So it's interesting that your background is helping to recruit people, or I'll say recruit, but educate people to go into the field of social work and behavioral health. What was that like? I mean, what were the challenges you had to get people to be interested in working in that field? Because we're going to talk about stigmas and perceptions, and I'm sure there are perceptions about people that say, oh, I'm not sure I want to do that work.
Absolutely. So I'll preface this that I'm a licensed clinical social worker. And so I had my training in that area. And, but I think the challenges are first that people think they're not going to be able to have a good life and make any money. And that is a real fear, mostly of my students' parents. Like, what are you doing to go be a social worker? And so, but then I found my students saying, I really want to help people, but going into mental health was a bit scary because they perceived that it was the stigmas and the stereotypical things they might see on TV or in movies that are not at all factual and are not true. The quote crazy people and how am I supposed to help them when it's actually a science, right? And helping individuals heal and recover from their mental health diagnosis. And so spent a lot of time with students talking them through that, actually engaging in internships and opportunities for them to really meet people and see that, oh, I do like this. And you find that folks are like, you're all in if you're in it. Like social work is a really wide field, but if you want to work in mental health, I could kind of tell some of the folks who were really, it just hit them. And so then we try to mentor them and bring them in.
Sure. So when we say mental health and behavioral health, is there a distinction to be made there?
So really, I see behavioral health as mental health and substance use. kind of together, and it impacts our behaviors, right? So whether you have an addiction to a substance, or you have a diagnosis of mental health, or you have both, I think that impacts what we call behavioral health. So it's the arena of that.
Okay. So the mental is what drives to the behavioral issues that you may have. Okay. How do you see that affecting the wholeness of a person? I mean, what do people struggle with the most when they have, particularly the mental health issues to start with?
So one of the things that we've talked about for a long time, and is kind of a misnomer, is that, that your physical health is just as important as your mental health. And people, I have everything above my neck up. That's where I'm dealing with my mental health, my emotional wellness. And so I think what's difficult is folks don't understand that that's all connected together. So my physical health can impact my mental health. If I have substance use diagnosis or some challenges, it can impact, again, my physical health and my emotional health. So you can't really get away from any of that if you are impacted. And so that's the whole person. And we have to treat that whole person. And so we have folks who maybe aren't having those difficulties right now with mental health or substance use. But in any given day, you don't need to have a diagnosis. You may have a more difficult day, experience some anxiety and depression, even if you don't have a diagnosis, but it impacts your physical health too, that whole person. If you don't get treatment, it can also potentially lead to some substance use concerns, because sometimes that is a way people, we call self-medicate. So feeling down, feeling anxious, if I just maybe have a drink, if I just maybe do this, it'll calm me down a bit. And that becomes very innocent in the start, right? But people are just trying to feel better. And then, gosh, that helps me a lot. And I keep doing that, and I keep doing that. So I hope that makes sense, that you see how it all fits together.
Well, I'm visualizing, the old adage is the chicken or the egg, but I'm really visualizing a circular reference of the mental, the behavioral, the treatment, the self-treatment, the self-medicate, and then now you're affecting medical, and then behavioral even further. And so that can be very challenging.
And fixing, supporting, and working on one, you need it both. You need, or all three. You need to
both.
Say, how do we look at you? What do you need, right? What are you struggling with? If you don't have a substance use concern, then let's work on your mental health and your physical health. If you have all three, we have to do that. And so that is where our industry's been going, is that whole person care. So you can come into an organization and you can get all of that there, instead of saying, okay, well, you have to go over here for your substance use, then you come over here to the mental health center, and then your primary care doc will follow up.
Right.
Organizations now have it all under a lot of them have it all under their one roof, or if you will, or a part of their whole system. In more of a comprehensive approach. Absolutely.
You say your industry, and what's the longevity of this industry? I think if I would ask my father about this, he'd be like, what is that? What is mental health? What is behavioral health? Like, just, I mean, when did this become not more mainstream, but I think it's much more talked about and understood. When do you see where there was a, wow, there's a tipping point? And I know COVID's an easy one, but
but even earlier
certainly
on,
Heritage has been around before that.
Yeah, Heritage has been around 68 years.
Okay.
And I think, and you look at some long-standing organizations. I was just on a call with a colleague who we were talking, he's been around 57 years. And so I think what changed is actually back in the 60s, kind of mid to later 60s, they started to realize that they weren't really treating people and helping people who are living with particular mental health disorders. They would hospitalize them, really warehouse them. And so
medicate them, lock them
absolutely.
up.
And it was,
there's your movies.
Yes, it is.
Yeah.
And some of what happened in those are true, with that people were hospitalized for a long time. Now, I don't want to sensationalize some of the other things, but we saw people being in those facilities for years. I had former clients in my past who'd been in for 20 years. So we started to see deinstitutionalization, to say, you know what, that was kind of the wow moment. And that was, you're going to get me on off script here. I don't know, but I love this stuff.
There is no script, Mary, no script.
But John F. Kennedy created the Community Mental Health Act that said we're going to move people out of state hospitals across the country. We're warehousing them. We're not helping them. And so that really started to change. And then those services began to come to the community. But we had to get funding for that. That's really when I think we became an industry, if you will. We began to have grants that supported us. And so instead of paying for folks being in a hospital for 20 years, let that money follow them out into the community so we can wrap around care and then help them in the more appropriate environment.
And I think you said getting the services into the community too. Whereas if we go back, I'm sure it was like, well, there's a mental hospital here and there's a mental hospital here. And, there isn't the location in individual communities that people can go get services.
Right. Really. I mean, kind of minimal being able to go in and see, someone to talk to and really none of the services we really have today, such as case management, crisis services, all those were a part of the Community Mental Health Act that said, if we're going to do this, we have to support that and create a continuum of services. And since that time, it's just continued to build and build, all while fighting stigma because people were scared. You're letting my uncle out and he's been in the hospital 20 years and he's not okay.
Right.
Well, we're going to support him.
Right.
So he is okay.
So stigmas, how do we go about dispelling some of the stigmas? How I guess back to educational aspects. I mean, that's as you're training people to go into the field, probably the first thing you have to do with them is help dispel stigmas to them. But then do you train them to dispel stigmas also?
Yes. It's really, I would train my students and say, this is like part of your job. Like if you're going to go into this, you're going to face those, first of all, and we need to advocate for our clients. And we need to educate the community because our clients are facing that every time they go out if we don't help the community. So it's an ongoing conversation. It's that advocacy piece to say, what this impacts everyone in our community and our nation. And so it may not be as severe in one person or another, but I can literally guarantee you that every person has a touch to this, whether it's themselves, their family member, a friend of a family, someone they work with, someone they know who knows someone who. And so we need to remember that we are all could be impacted ourselves, but also don't assume people are okay. When you just look at them, they say they're okay too. We don't know what people's struggles are. And so I always want to say that, and I remind, this is my continuing education that I do in advocacy, is just remind people that this could hit you too. And once people can see that, like, oh, I would not want that for my family member to struggle, or I can't imagine going through that. It's not about pity or, having sympathy, but it's about helping support the work that happens in behavioral health and champion that people should go get help. We put up a lot of barriers for people to get help. Stigma related to you're pretty weak if you need to go get help. Like you need to fix the problem. It's you, as opposed to what are you experiencing that leads you to feel this way or have these symptoms. Does that make sense?
Yeah. I mean, in taking it back to medical health.
Yeah.
If you have high blood pressure or a bad knee, I can't fix that.
Right.
And there are things that you can and can't do on your own, but sometimes there are other treatments you needed or other assistance you need.
Absolutely. And so that's the part about that physical health. It's the same thing. We need to treat that mind. We need to treat that substance use. And yes, people have choices. And I hear that a lot too. Well, it's a choice to use a substance. It's a choice to not get, mental health treatment or take your medicines. You can say that, but there's a lot of barriers in the way for that.
Right.
And so people's behaviors are based on things they're experiencing. And it's really, really difficult to have individuals understand that if they have never been walking alongside someone living with that. Yeah.
So I kind of staying on the stigmas in a sense, and to dispel some of that here. I think when we talk about behavioral health and mental health,
Mm-hmm.
there are the common, I'll call it the crazy person on
Mm-hmm.
TV that we think and imagine and think the entire operation is full of that. And I know it's not. I know that's probably a very I'm sure there's some degree there's some that are there that have some serious issues.
Right.
But what are more of
Yeah.
I don't even want to call them mild cases, but what are
No.
issues that people are dealing with that if you just saw them, even had dinner with them, you wouldn't really
Yeah.
know?
Yeah. So when we look at the United States, 19% of the population, and that's what we know, are diagnosed with anxiety. Now,
Okay.
I can have anxiety and not be diagnosed, right? Haven't maybe gone to get that diagnosis. But that's a really kind of silent, right? I can be having dinner with you and I don't know. And what do we think anxiety looks like? Does it look like, oh my gosh, I'm so stressed out? Well, it could. It could also look like someone's kind of withdrawn, kind of calm, even though inside they're really, really anxious. And so trying to really label that is and understand it is difficult. So we have people every day that we interact with who have anxiety. The next most common diagnosis is depression.
Okay.
And that's at 8%. But again, there's many more, but that's what we know from the data of actually being diagnosed. And so what is depression? You may think someone's like supposed to walk around and very sad all the time. Maybe they are, but also people are pretty good at putting on that face, if you will. And you would not know how debilitating that can be. You know, I've known a couple friends who you would never know it when you saw them interacting at work, but all they could do is wait to get off work, to go to bed. They were so depressed to just get through and get up the next day. You don't see any of that.
Because they know they're feeling it, but they put on this.
Yep.
Because that's what you're supposed to do. It's supposed to look like and act
and how can I be a professional, a social worker, a professor, whatever your field is, that it says, well, if you can't handle that, then you're probably not the person to help me. And so it's a real battle within folks. And so the way I address stigma is just let's have conversations. Let's make it okay to talk about it. And so I want to mention too, in conjunction with depression, the other kind of most common area is actually what we talked about earlier. 8% of the population that we know has a mental illness diagnosis and a substance use diagnosis. It is incredibly common for that self-medicating piece.
Okay.
And so I think that's, again, we go back to treating that whole person, all of those areas, the physical, mental, and substance use areas. And so people can actually easily not understand that they have that. They're out socializing, they're experiencing that. Their friends may never know that they actually have a substance use disorder if it happens to be alcohol or any other kind of drug. Because that's what we do. We go out and we have a drink.
We're all medicating. It's become a joke too of wine time or
absolutely.
And that could be a whole nother topic.
It could be. We could spend hours
alcohol.
on that. Yeah.
So what? And you may not know this, I guess, of the mental illnesses of the general people that seek treatment, anxiety and depression, what percentage is made up of anxiety and depression versus other mental health issues? Right.
So within that, there's also what we call at times co-occurring diagnosis. So having anxiety and depression together, having post-traumatic stress disorder, bipolar disorder is a significant number of folks who experience that. So when you talk about, we kind of categorize, if you will, when we're looking at diagnoses, there's what we call severe and persistent mental illness, which would be more an illness like schizophrenia.
Okay.
Because of the debilitating factor in that. And it all focuses on I know someone who's lived with schizophrenia who was able to work full time, raise children, and then I know others that were so debilitated they could not live on their own. A lot of it has to do with what's happening in your world. What are your supports? When was the diagnosis given? Because the sooner the better. What medications you can tolerate. So there's a lot of factors that fit into all of these. And so we see a range of folks in behavioral health with all kinds of diagnoses. You could have an adjustment disorder. Someone's, transitioned in their life and they're really struggling with that. That's a diagnosis as well. I mean, there's hundreds.
Sure. How do you feel mental health and behavioral health, and so kind of all encompassing then, is looked upon in Decatur?
So I would say that our community supports and understands the need for mental health and substance use treatment. But I've said this before, I think there's still a lot of stigma of where service should be, they should be in a certain place. And I think folks only see it as a certain population. Again, we serve anyone, and most behavioral health centers do. People with private insurance can walk in our door. People on Medicaid walk in our door. And so I think they see the need, especially for youth, and that just became very apparent during COVID. But they're supportive in that way, but I think there's a disconnect on how those services are provided and what actually happens in the doors of, in particular, Heritage and any other organization. My colleagues across the state face a lot of that too. And so that being said, I've spent a lot of time in my first couple of years to come in and see what we offer and how we can help, whether it's you or a family member or anyone you want to refer here.
Do you feel like the understanding of the need, you mentioned the youth, there's more of an understanding of the need for youth. Do you feel like, adults, do you think there's a better understanding of the need for adults now?
I do. I think, and people are talking about it. It is, when one person speaks about their experience, you're like, oh, you too? I've never told anyone this. And so that is a push that we're seeing. And one of the things that's happening in the industry, if you will, is people with what we call lived experience. So someone who has had a mental health diagnosis or a substance use diagnosis and are in recovery are embedded within providing services. Because if you haven't, I could be trained as a social worker, by that best place ever, and I'm going to have those skills. But if I don't have maybe that lived experience to really meet someone where they are with that, so we do it together, right? And say, maybe John and I are working with someone, and John shares about, I had a diagnosis, not to take away, but to say, I had to sit in an assessment one time, and it was scary, and it's about how to support that person. And how to say, because it was scary, maybe because of the stigma and that you feel like it is your fault. And so they help really support individuals and normalize that this is okay.
Do you feel like the mental health community in general is moving forward and progressing with the access to it and lowering some of those stigmas?
I do. Actually, in the last, 4 years or so, 5 years, it's kind of been a game changer. I will say in Illinois, a lot of states too, but in Illinois, what we've seen is a lot more funding. Because what we know is when folks are not doing well, they're missing work. Right? They're struggling supporting their kids and being the great parent that they are, but they can't do that right now. And so it's disrupting families. And so if you invest in, the community to say, here's services and here's how you can have access to it, telehealth, We can come to your home. You can come into the organization. We're going to reduce the costs of them missing work, them having to maybe pay for childcare differently or have their family members watch their children, whatever that might be, so they can be well and be that person that they are. And so we have been very, very fortunate to have a lot of funding, and the federal government's funding as well.
Okay.
And so they're trying to, there's something called a certified behavioral health care clinic, which Heritage is now as of October 1st.
Okay.
One of 19 organizations in the state, where the federal government has been supporting us to say, you need to do these services. And they gave us a couple grants totaling over 6 years, $8 million.
Oh, wow.
And now that's coming down to the state level, and it will be embedded in the state. So it has to do with Medicaid reimbursement, because that's the other problem. There's a lot of red tape and a lack of funding to have true high quality behavioral health services.
Mm-hmm.
It costs to pay for staff.
Right.
The social work world has been, I'll help and work, but you need to make a living.
Right.
Right. And so we've really elevated the work that happens. The folks that do the work every day with individuals we serve, it is tough work.
Talk about that.
Mm-hmm.
That's something I put as the staff and the people
Mm-hmm.
you have. I mean, and you mentioned that, it gets them and they want to help people, but, why? How do they cope in a sense too?
Right. One of the things when I was teaching is one part of a section of my course was like, what's your motivation to do this work?
Mm-hmm.
People say, I want to help. Okay, what does that mean? Do you want to help because you didn't have help? Because you did have help and it went well? Do you feel compelled that this is just kind of your calling? So we would kind of talk those through. And because what is helping someone? Is it fixing your problem? We're not going to do that. We're going to be on the journey with the client. And so it's a lot of that. But when folks really tried to prep students to get in, that there's a lot, like movement is slow. Like you're not, that win might be that someone took their medication today.
Right.
And that's amazing. Or it could be someone moved into a new home or new apartment and as they were living on the streets.
Sure.
And so I think it's trying to prepare prior to going to the field, but also the staff that are working in it, that it's okay to say, oh my gosh, that was hard. And to talk through that and to say, I'm angry about that. I'm angry that they didn't do what I thought they should do. I kind of know, and really help staff understand that we have to walk side by side and, give them opportunity through supervisions and supports to talk about what they're experiencing. And when there is unusual events, which happen a lot, that might be out of the daily routine, providing supports and debriefing for that. There's a lot of compassion fatigue. So I'm here working with you and I'm taking it home. And there's no way not to do that, but there are ways to reduce it.
Right.
I think finding ways after work, if you go home to your family, maybe I used to commute the first amount of time before I came to, when I was at Milliken for about a year. And I loved the hour back that I would just leave it. And so I tell staff now, whether it's 2 miles across town or you live in Sullivan, use that time. And where's your cutoff? When you hit that gas station, you're done and you're committed to not thinking anymore about it.
Yep.
And then you start back up in the morning.
Yeah.
It sounds easy, but it's not. But
I know being in real estate is a very tightly wound and highly focused and fast moving business and conversations and headspace all the time. And I found struggles that I'd come home and I'm just wired and berserk and so we actually created a routine. We'd come home and I'd go change. And I just go up and get into my comfy clothes for the evening, and then that helps my mindset change.
Yeah, no, this is Chris at home. And this is I can now connect.
So that's a good strategy, I think, for that. A little tactical here. How many staff are there as part of the Heritage system here?
So we actually have 466 staff positions.
Wow.
We have over right now about 100 open.
Oh.
So recruiting is right. Yes. And so, and part of that is that growth of being that certified behavioral healthcare clinic. In order to provide those services, we have to have those staff. But we are able to so we have some remote positions. We actually have folks in 9 states. So some of our billing folks, we have remote therapists. And so really took advantage of COVID with that to be able to say, well, that's a smart thing to do.
Sure.
And then, again, we have an array of we have 51 different programs that are under those areas of primary care, mental health, and substance use. And so we're spread all around Macon County, and we're also in DeWitt County.
Okay.
Yeah, so we're serving that group.
Okay. What percentage of the people you're serving actually come to a facility versus have a tele or remote help?
I would still say we're probably still, it depends on the service. So I would say we're about 25% at this point are maybe using telehealth. And that could be psychiatric. It could be a therapy session. It could be a touch base with a case manager. So I think part of it has been, I think we have been in the industry a barrier to telehealth. We believe, and I thought this as a social worker, I can't read your body language. I can't see your cue. We can. The technology is really good. And so if someone isn't going to come in the building, what is better than to say, okay, let's start here and we'll do telehealth. And if that's the way we go, that's the way we go. Yeah.
And if that helps you, that helps you.
Absolutely.
And if we need more, we can certainly do more.
And a combination, you can one time you can use telehealth, another. I mean, we're doing it for physical health all over.
Right.
Oh,
yes.
I mean, phone calls with our docs.
Right.
And, and I believe that the individuals we're serving at Heritage should have access just like anybody does for any healthcare. What I get from my insurance company, that we should be providing the same thing to say, yes, you can have that service.
Do you feel homelessness is a word I wrote down and not to play the chicken or the egg here, but how much of homelessness do you see a lot of it does stem from mental or behavioral health, which then could be alcohol and abuse of drugs? Where does that circle fall? And I know that's probably not an easy question to answer.
I could talk all day, but so when I was at Milliken, one of the things I did, I worked for 10 years in the community working with some colleagues on homelessness and doing kind of sitting on committees and doing the point in time count in Decatur and Macon County and then writing HUD grants to bring dollars in. And so this is an area close to my heart. There's a rise very much. And I really think it can go either way. If you are losing your home, even not yet you've lost it, that's going to cause you anxiety. That's going to cause you stress. Maybe you begin to use a substance and coping and then because you're not feeling like you get the support you need. And then you end up, maybe you lose your job then because of the substance use. If there's a consequence there for that, unfortunately, then you might be on the street. You did lose your house. You can't pay. And so it can lead to homelessness, but also folks who've lost their homes, they're on the street, they begin to, at that point, have, come a little bit later, maybe having some of those stressors in their life and dealing with absolutely anxiety and depression. And again, trying to get through and cope. So it is hard to pinpoint where it starts. That again, chicken or the egg, but what we know, I don't want people to assume that all people, who are experiencing homelessness are all they don't use substances. Sure. They don't all have a severe mental health diagnosis, but it runs the gamut. But you can imagine living, even if you're in a shelter, how difficult that could be. I had experience with my students to live in a shelter on Skid Row for 4 days.
Oh.
And it was life-altering. It was the most overstimulating environment. There were 1,500 people in the shelter.
Oh, my.
And I knew I could go home. And it was,
Right.
It's hard to describe. And so I often think about that back when I'm thinking about what is John feeling? Well, he's maybe in a shelter, he's maybe on the street, and that's got to be pretty terrifying on what that looks like, what people are assuming about him or her, if it's a woman. And I think just trying to understand from that perspective why people might respond the way they do in situations.
Right.
So yeah, there's a lot there.
There's a scene, the movie Pursuit of Happiness with Will Smith and his son, where they end up getting evicted, and he's got to grab his boy and catch the bus and get across town and get on another bus and to get in the line, and then boom, it's shut down. And there's actually the scene that night where they sleep in the subway bathroom.
I know that's
you can just see it in his face of just what that feeling is, and that was one night in a movie.
Yep.
And to know that's a real thing that people are dealing with.
One of the things that when we lived in the shelter, we stayed, so we didn't take any beds on top. There's this rooftop place, and we got tents, and some students were in theirs, and I was in mine. And it stormed like horribly. And I woke up to all this water in my tent. And I got out, and I was so distraught because all I could think of is all on Skid Row, the 50 block area. There's tents. Again, I'm okay.
Yeah,
but I
you're going
thought
home in 3 days.
This is all they have. Right. And so that's where that kind of education comes in with students to try to understand that we all behave certain ways and have responses, but let's meet someone where they are and understand and be what we call trauma informed. That the expectation we have from you should not be, well, let's stop your substance, and even let's move you in an apartment today. That's a lot. That's a huge change. And you'd think, well, why wouldn't you want one? Wow.
Right.
I don't know how to do that. I'm not comfortable. Am I going to trust? So there's so many levels, and we provide support services for homelessness and work part of the continuum in the community. We do that at Heritage.
Okay.
And you want to fix it. I just want to say, here's an apartment, here's everything you need, and you'll be fine, and I'll check on you, and I care about you.
Right.
And it doesn't happen that way.
Right. Why do you do what you do? You could be in education. You could take summers off and
I
take
did
a month
for a while.
Christmas. And
it's funny because some of my colleagues joked about that. Like, what are you doing? Because, you really don't have vacation days in academia. You just have the breaks and you don't ask off.
Right.
You just do.
Right.
And honestly, it was at this point, since I'm not doing direct service, I wanted to be in this role to see if I could affect change and to support staff in the agency. And really my focus is access to care for those we serve. Like, let's push down those barriers. And I think I've learned over the years, 10 years ago, I don't know if I'm effective now, but I don't know that I would have been as effective. I think as I've learned and grown that, here's what we're going to fight for. And here's how we need to deliver these services. And so that is just what I care about. It's that helping people now in my life from this lens to be able to stand up and say, we are here. We can help you.
Right.
And when something's going right, we'll champion that. And when something's going wrong, we'll fix it in our organization and we'll do what we can. I want to be here for another 68 years. I mean, not me, but Heritage.
Right.
Yeah.
So you said something about like 10 years ago, you didn't know if you would be as effective. What's the combination of why are things more effective in change now?
Well, I think it just personally for me, it's my experiences led me to feel like I had gotten to be involved in more things over time related to policy, related to how things work. And so being able to manage and lead an organization in that way of, right now, 300 and some staff, soon to be over 400 and some. And so how do we champion that mission and prioritize what we need to do? Because everything's important. And I think just with age and experience,
sure,
you get a little bit better at it.
You've got more tools.
Absolutely.
And you're leveled up.
And confidence to say, well, no. Well, and be willing to say, all right, that didn't work, or this did.
Right.
Mm-hmm.
Mm-hmm.
Yeah.
Why do you think mental health and behavioral health and access to it is so important in our community, in Decatur?
Well, I really believe that to be a healthy community, we need access to all kinds of care, right? So we are really in a healthcare desert, our physical health and mental health. And so fighting for that access, again, it ripple effect. The healthier we are as a community to be able to live and work the way we want to and can, we're better together in that way. Businesses will prosper because people will visit those businesses. We'll be healthier in our relationships. We'll make good decisions about how we'll handle our tax, money and what we need as a community. And so I think it's really important, again, to normalize where the health comes in. And when we've done through DMH and HSHS, they've both done community health surveys, and mental health and substance use rise to the top every time. So those are things that we try to connect with them and work on. And so again, I think it's always been there, but we see it more now because I think people are talking about it. But there's still a lot of people who are struggling and you would never know, or we don't have the statistics. You could probably double at least the statistics that I've given you, that truly if everyone had that anxiety diagnosis, we'd be at 40%.
Interesting.
And so, but when folks aren't able or feel like they can go get help or feel stigmatized, they're not going to do it. So we'll never know.
Right.
Yeah.
Right. Interesting. Switching a little bit, how do you see Decatur as a whole? I mean, certainly you've got it from the lens that you're in, but you're a resident here now. And how long have you, I know you moved from Bloomington, but how long have you actually been a resident here?
So now I have lived here, oh my gosh, it has been 15 years.
Okay.
So been in the community before that, but, was commuting. And I really loved Bloomington Normal where I lived and thought I was a part of that community. It was a really great place. But I don't know. There is something about Decatur. I feel that it is in even it's smaller than Bloomington Normal, but there is something about the folks that live here. I think that people are kind. There's a lot of collaboration that happens, and a lot of we're fighting for our city. I love going out in the community. Every time I go out, I see someone I know. Or even if I don't know them, we're saying hello and how are you?
Sure.
That didn't happen. It was a little more, I felt like siloed a little bit more, I think, in the bigger city. And so I don't know, it just has, I always say that I think Decatur has the self-esteem problem. I think people tend to talk about Decatur in a way that I was very surprised when I started hearing that, because it's a gem.
Right.
And every city has problems, issues, but when you really look at what happens in our community, it's wonderful. And so, and I heard that a lot from my students. They're like, I can't wait to get out of Decatur. And then they're back. I'm like, oh, look at you.
Right,
You really like Decatur.
Right. Not so bad, is it?
Yeah. And so really, I'm a huge champion for Decatur. I think a lot of it, and a lot of, we have great leaders. And again, I'm fortunate enough to work with so many agencies that are just driven to help. So, yeah.
I think that friendliness is, it's really kind of the rural roots.
It is.
When I was in banking, I had a banker that moved, and actually moved from Indianapolis to Decatur. And he's just like, Decatur, there's just something. And he said, it's that blue collar mentality. Yep. He's like, in Indianapolis, people got to the office whenever they got to the office. He says, I come here, people are here at 7:30 in the morning, and it's right. Kind of that rural, the farmer mentality, the blue collar mentality, which, I'm teaching my kids to drive. My daughter's 15 now. So we were kind of practicing the farmer wave, or the, you're at the stop sign, you wave them through.
Right.
And so I think there's a lot to that where, in some of the bigger cities, it's like, well, I'm here first, I'm going,
Absolutely.
and whether it be on rural rules of the road or whatever. But that's interesting to say that, you feel like you can just say hi to people.
Absolutely.
More commonly.
Absolutely. Sometimes I barely get up to my office on the 5th floor because I'm too busy saying hi walking up the street to work.
Sure.
I'm like, I just love that.
Yes.
I love that.
Absolutely.
So,
What are you excited for about Decatur in the future? Where do you think things are heading, and what do you think is going to help, I don't even want to say transform, but help continue propelling it forward?
I do think there is some great, initiatives happening in growth. And I do think a lot of it is some of the younger generation sticking around, those that committed and going to take our places down the line, which is wonderful. I think a lot of what's happening kind of in the school system and some of the changes, positive changes that we're looking to make are really, I think I'm very hopeful for what that means. And again, I think there's a ton of caring and wanting to be that great system. And I think you and I both know, being a part of moving forward with strategic planning there's a lot of great things. But it takes a community to do that.
Right.
I do feel like there's also just passion of people that they are championing things that are important to them in the community and sharing their voices. So I don't know. I'm hopeful that we continue to move forward in a positive way. And I know I'll be here and Heritage will be here.
Sure.
And
I think we'll all be here.
Absolutely.
Yes. It's funny you mentioned the younger generation sticking around. What I'm seeing is a younger generation that's moving here that isn't from here. They're from some other part of the country, different states. And they come here and they think this is the greatest place ever, and then they hear the self-esteem things. They're like, what's wrong with the people? Why are they saying these things?
Right.
So it's really interesting to hear you point out, what the younger generation can do for the future, because I think that definitely is something that, we do all need to start looking at, or who are the 20-somethings and 30-somethings that are going to continue to carry these torches. Also the passion. You mentioned the how people have passion for, sometimes it's their project. And I think sometimes we see things that come, they live for a while and they don't succeed. And sometimes I think that's okay. And a good example that people, if you're watching and you don't know what the Decatur celebration is,
right.
I mean, it was a thing for, I think, 20, 25, 26 years.
Absolutely.
That was driven really by the passion of kind of a small group of people.
Right.
And once that small group of people ran out of fuel, and there weren't enough other people that had that passion, it dies. And that's okay.
But is that not success, right? Right? It was incredibly successful.
Absolutely. For the time that it was a great success. And then now what has happened, other things are spawning, other things are creating, other things are more organic, other things are more near and dear to the leaders that are passionate about it.
Right.
And
we need that movement. We need that transition.
Yes.
And we all love, those traditions that happen. But I think it is time. I mean, that's incredible success, and that does allow to open the door for other things and be creative and say we can do things differently now.
Yes.
It doesn't have to be this way. One of the things I'm known for in the agency is I ask why a lot. Not to judge you or not to say it's bad, but tell me why we're doing it. And if you hear, well, because we've always done it that way, well, it is 2024, and there might be other things we're not aware of. I don't know. Maybe it is the best way. And so being able to look at those things and say, how can we engage more of our community? I mean, you had all these folks who came to Decatur Celebration, but you had a lot who didn't.
Right.
Might be different for them to come something else.
Absolutely.
I mean, looking how our community has evolved and who we are today.
Yes. Yes. So how the community evolves and how we continue to evolve in the future. How do you want to see, whether it be stigmas or access to mental and behavioral health, how do you want to see that evolve into the future?
I want to be, for folks to be able to walk in our door without having to call me first and say, I'm kind of nervous to come in. I don't want it to happen. And it's so that they can normalize. And it's mostly because they don't want to be seen, or they're scared of what people might think of them. I want people to be able to talk openly as they feel comfortable, and to not take on guilt for what they're living with and what's happening. And I want that access to care to just continue to grow. We've made great strides, but it's hard. It takes staff, it takes 24-hour programs, and it takes breaking down barriers between entities as well. And we have great relationships. We just met with all our law enforcement colleagues and hospitals just yesterday, and talking about what do we need to be doing differently. So I think it's continuing to have those ongoing conversations. And like I said earlier, I shared with my students, it's an element of your job. You have to be doing that. Now, maybe not what I'm doing, because, but talking to your clients even about stigma, and that helping them understand that it's okay. So I really, really want to see that acceptance continue to grow, is probably the best way to say it for the services we offer.
Very good. Thank you so much.
It was wonderful. Appreciate it. That was fun. I think you and I could talk forever.
That was really a great conversation with Mary. I really enjoyed hearing kind of how we got to the treatment of mental health and behavioral health, and really moving it from a de-institutionalized system to really where we're at now, where it's more community-based. And really one of her passions is to have greater access to mental health in the future, and really normalizing mental health, and letting everyone know that if you need help, there is treatment out there. So again, we want to thank Mary for joining us.